My name is Laura Faree, and I want to thank you all for joining us today. I'm very excited to continue this 8-week virtual series for you guys. As we get started, I'd like to give you a little background about myself. I've been with WellSpan for about 4 years now, working as an exercise physiologist with our outpatient rehab team in our WellFit program. I'm also a part of our sports medicine team, which is why I'm here with you today. The pandemic that we are experiencing now has challenged us with many ways to be more creative on how we can help the community. We have put together a small group of diverse, experienced, and motivated individuals to continue to make a difference, be available, and help those like yourself. Our goal with the series is to support you as a coach during this pandemic by providing education and resources to help you stay active, take care of your body and mind, prepare for upcoming seasons, and prevent any injuries for your athletes. Today, I have the privilege of introducing our guest speaker, Mitch Crawford, who will target the topic of the week, which is substance abuse. Mitch is the Director of Addiction Services, serving the entire WellSpan system, but is physically located at WellSpan Phil Haven in Mount Gretna. He has been working in this career for 5 years and has been employed by WellSpan for the last year. We asked Mitch why he is interested in sports medicine, and he responded by telling us he has been an athlete his whole life, including now. As a psychiatrist, he's very interested in the connection of the mind, body, and spirit in regards to human performance. Mitch is originally from Lancaster, PA, and his favorite sports team is Tottenham Hotspur, English Premier Soccer League. But before he gets started, I wanted to address a few housekeeping items. We will have a Q&A after the presentation. You can participate by submitting questions throughout the presentation or waiting until the end when the presenter has finished. If you have not done so already, please mute your computer at this time. For security purposes, the host has the capability to unmute the participants as needed. Thank you. And now let me introduce Mitch.
Hello, everyone. Just please give me 1 second as I share my screen. Perfect. Excellent. So thank you so much for that very kind introduction. I really appreciate it. It is such a pleasure to be here and to talk about this important topic with you. Thank you for all of your hard work and effort guiding young student athletes on this path. And so hopefully this can be helpful for you. We'll leave some time at the end for questions, and please feel free to ask anything. So I am obviously Mitch Crawford here, the presenter. Another one of my colleagues, Ponta Faramond from New York University, also contributed to some of this content. We create and share content together. I have no disclosures. In academia, that's the fancy way of just saying that nobody pays me for my opinion to talk well about them or poorly about other people. I'm not connected to any pharmaceutical companies. I don't get any money for doing any research for companies or anything like that. So I always start off talking about a case, and I should tell you guys as well, I'm actually using the exact same slide set that I shared with the athletes yesterday. So you can see what they received as well. And I'll talk just in a little different way with you and presenting the information in a different way, but what you see is what they saw as well. So this case, just thinking about a 17-year-old soccer player, multi-sport athlete, very talented. Soccer was the main sport, was a goalie, multiple knee injuries. The last one required surgical intervention, was struggling with multiple things in her life, was really struggled to stop using opioids after the surgery. And then when they were not prescribed anymore, started using illicitly and started using heroin, first by snorting it in the nose and then by injecting it. And then really had a difficult time finding recovery in her life, and had mixed results, had some really good success and sometimes where she really struggled. And the unfortunate part about this case is that this person actually died from a fatal overdose after a significant period of recovery, had a slip, and return to use. And with opioids and many other substances, that's all it takes to end somebody's life is one slip. And I share this with you to kind of lay the groundwork on why it's so important that we talk about this, what happened to this athlete, and also to share with you that this was my sister. And so this is part of the reason why I'm so passionate about this field. So we'll talk briefly today about just what addiction is. We'll talk about addiction in adolescence, and then we'll talk about some risk factors that are unique for our athletes. And so there's really two big governing bodies within the field of addiction. One is the American Society of Addiction Medicine, and the other is the American Academy of Addiction Psychiatry. And they work together. I'm actually a member of both, and we contribute to both. We present research at both. And this is the ASAM's version of addiction, and I like this one very much for their particular part that it calls out addiction as being a chronic disease. And so this is a lot different than the way that maybe when we were growing up and we thought about addiction, and maybe it was presented as a moral failing or people just needing to get their lives together or making just poor choices. And we understand now that it's a lot of interactions, what we call multifactorial, between genetic predispositions, so what they have in their body before they started, the environment, so what they were exposed to. Did they have traumatic childhoods? Did they have a parent who struggled with substances or shared alcohol with them when they were 10 years old, for example? And then also other events that occurred, like exposures. Did they get injured? Did they get prescribed opioid medications that they otherwise would have never come in contact with? And thinking about it in the disease model is really important because we have a lot of evidence to support that. And so there were some really seminal papers that came out showing this, imaging studies of brain showing that someone who is struggling with a substance use disorder actually has changes that you can see when you scan their brain, both in the size of different areas of the brain and the way that those areas talk together and are reinforced. And if you understand this as a disease, then you can understand more about, one, how we talk about it, but then two, that prevention and treatment can be effective. And so when you look at other chronic diseases like diabetes, high blood pressure, COPD, asthma, et cetera, the treatment outcomes and adherence to treatment are actually very similar. And so say, for example, someone who has high blood pressure, the amount of times that they show up to an appointment or adhere to their medication regimen, taking it as prescribed, for example, and modify their environment, like their exercise and their diet, is very similar to folks who are struggling and being treated for substance use disorders. The next slide is from the DSM-5. So this is the psychiatrist and therapist and the behavioral health side of how we think about addiction. And these are just bullet points. I'm not going to read these to you. You need to have 2 of these to qualify to have a substance use disorder. And then the more of these that you have, the kind of qualifier of the substance use disorder, so whether it's mild, moderate, or severe, can be assigned. This is information I shared with the athletes yesterday. So these are studies that are looking at primarily high school kids. And so, you know, everyone knows and thinks about alcohol and cigarettes. And so the good news is that alcohol is on the decline in this age group. So folks who are in high school, you can see we're moving downwards in terms of any use within the last year. And then also significantly a decrease in binge drinking, which can be really problematic. The unfortunate news, and this is probably no surprise to you, you know, as we see a decline in combustible tobacco products like cigarettes, we're seeing an increase in these vaping products. And so this is a pretty dramatic increase. The increase in 2 years ago in this study, when vaping really started to take off, it was the greatest year-to-year increase in any substance that we have ever been studying substance use in this population, just to kind of put that into perspective of how serious this is. And it's not, folks would like to think sometimes that there's little harm involved with this, but there actually is a significant amount of harm, and we're even just starting to realize more about that. There's a lot of harmful chemicals like formaldehyde and heavy metals that can contaminate these substances. And of course, there's new conditions that we're starting to see crop up now where folks are going into pulmonary failure and needing to be on ventilators, and it's really serious. Last year in this study, so this is the most recent data we have, this was actually the second largest year-to-year increase that we ever saw in a substance, one being vaping of nicotine that we just talked about. This is the second highest increase, which is the vaping of THC, which is the psychedelic compound within cannabis or marijuana plants. And so this is a really concerning trend. Of course, we understand more about nicotine and the other substances that we know and are learning are in the vaping products for nicotine, but we're starting to learn more and more about how harmful the use of THC in marijuana products can be in the adolescent population. Concerning about this as well is understanding why folks are using these products. And so the largest reason that teens reported for trying to vape, and this is vaping THC, was to experiment and to see what it looks like, or what it's like, what it feels like, or because it tastes good, or to have a good time with my friends. And so the good part is that if we understand that these are the reasons that folks are trying it, we can intervene and share with them, what the risk is of doing this, to experiment. And you're seeing a large proportion of folks doing this, it would suggest that there is a perception of very little harm. For example, you wouldn't do something that you knew was going to be fatal just to see what it felt like, right? So you're more likely to do something that you think has less harm to see what it would feel like. So we can do a better job, and we are, all of us together, in helping folks understand that there's significant risk. And I put this slide up here to talk a little bit about that significant risk. So the folks that we're talking about, adolescents, and really in that age group, we're talking about 12 to 18, 20 maybe year olds. But really the brain doesn't stop developing even until around 25. And so the folks that we're really talking about in that 12 to 18, 20 year age range, they're really having a really impressive and dramatic change of their brain, working from the back to the front. And so, it's a cruel trick that nature plays on us in some ways, that the brain develops from the back to the front. And it makes sense, though, because the areas that coordinate movement and balance, as an example, are in the back of your brain. So that's why my 2-year-old son can run around and kick a ball and throw a ball and have a lot of fun. But the really complex decision making and things that we call executive function are in the front of the brain. So that's really where the really important decision making is going on. And that's what gets matured the latest. And so it's the cruel trick that we can run around and do things really early, but we make terrible decisions at times because our brains aren't online. And the way that maturation happens is what we call reinforcement and pruning. So reinforcement would be, this is a pathway, this is a connection from one structure in the brain to the other that's really important and really powerful, and we want to strengthen that pathway. But there may be 10 pathways going there, but we only want one of them. So we'll reinforce the one, and then we'll prune, or we'll take away the other 9. And so it helps get our brain to be more efficient and helps connections be better. And when we interfere and we provide the brain with substances that it's not supposed to come in contact with at that time, it really can cause damage in that maturation and reinforcement and pruning structure that happens. And we're understanding more about the risk of THC, or just thinking about marijuana or cannabis in general in that process, because we know now, looking at some studies of adolescents that have had only 1 or 2 uses of marijuana, that when they scanned their brains, there was actually statistically significant differences in volumes of certain structures within their brains. And that's just from 1 or 2 uses. So that perception that folks feel from society that the there's a lack of risk is actually not accurate. And it's actually more harmful and risky for folks who are in the adolescent time period. And we can certainly talk more about that at the end too. There's more studies looking at the risk of psychosis and whether or not that is lasting. And there's many other risks that we're seeing highlighted in cannabis use. So this is just some overviews looking at illicit drug use in the past month, folks 12 and older. You see here that Pennsylvania is about right in the middle compared to the rest of the country. And then this is illicit drug use in the adolescents, so 12 to 17 is how it's defined here. And you see Pennsylvania is actually doing really well. Blue is the lowest percentage of folks. And then you see methamphetamine use in 12 and older, and you see blue again here in Pennsylvania, which is good. And I show this to highlight that the rest of the country is really struggling with stimulants, methamphetamines, and cocaine. And we're thankfully spared a little bit. That's changing, but we're spared a little bit. But where we're not spared and really being impacted much more than the rest of the country, and I'm sure this is no surprise to you, is with heroin and with opioids. And so you see here the red is the highest percentage, and you see Pennsylvania right there with the highest. And so just we're not going to go through this. We're not going to talk about receptor kinetics and dynamics, et cetera, but opioids are just anything that interacts with the mu-opioid receptor in a positive way. So if it binds to that receptor and activates it in any way. And so, classic examples would be, heroin, oxycodone, codeine, morphine, et cetera. But also thinking that tramadol is also an opioid. And so, when I was in medical school, we were taught that tramadol wasn't an opioid, and now we understand more that it is. And I bring that up because that's a medication that is coming out more so in athletics, in that it has been used in the past for maybe some questionable reasons. So just to highlight that tramadol is in fact an opioid. And what does this really translate into is, unfortunately here, we call this a heat map. When we look at the incidence or the amount of times that an event occurs over a geographic region. And this is overdose deaths that are opioid related. And you can see here in Pennsylvania, again, we're in the highest region. So it's unfortunately not only folks who are struggling with the use of opioids that is really concentrated in Pennsylvania, but also folks who are dying from the use of opioids. And so the DEA, the Drug Enforcement Agency, and the CDC, the Center for Disease Control, have noted a growing number of opioid users are current or former athletes, which is an interesting trend in the sense that even when I started my training, we were still learning that being an athlete was a pure protective factor, in the sense that, it was good for pretty much every aspect of your life. And not to suggest that being an athlete isn't still a really positive thing. I'm an athlete. I hope, my children become athletes. I encourage everyone around me to be an athlete. But it's not that there isn't any inherent risk associated with it anymore. We're starting to understand more about this. And you see the kind of the media take this on as well. You see probably billboards sometimes when you travel, or you see many articles, Facebook posts, etc., highlighting that we're starting to understand more about this. And in the literature, when we look at this, we're starting to think that this is really like a triad. So like a triangle that are of interconnected events that could be the possibility for what's happening with athletes. And that is that they're a higher rate or susceptibility to injury, and they have more access. And we'll talk about these in a little bit more detail. And then they also have pressure to perform, and they're all connected. And so we'll talk about injury first. So it's no surprise to anyone on this call that being an athlete, you're probably more likely to get injured than someone who leads a more sedentary life and isn't competing. And so there's a lot of injuries, and a significant amount of them require surgery, and the significant amount of those surgeries require exposure to medications to alleviate pain. And in this study, they were estimating 1 in 15 people who were given an opioid prescription will develop an opioid use disorder. In other studies, it's as high as 1 in 8. And so it is a really significant risk. The pressure to perform it can be really tough on folks. Some people feel this more than others, whether it be just maybe butterflies before they're going to start a game and the national anthem's playing, or maybe it's something that they think about every time they're not on the field or the court. And so a lot of folks will be worrying that if they don't have a good game, they're going to let their team down, or they're going to let their parents down, or if they get injured, that they got to return to play really quickly, because if they don't, their team's not going to win, or they're letting them down, or they're not going to be with their brothers or their sisters or their colleagues. And so sometimes what we see is people will take medications, and we're talking primarily here about opioids, to reduce pain and to come back sooner for these reasons. And then there's also an idea, especially in some contact sports, where folks are trying to achieve some painless play. So this is preemptively taking a medication to dull the effect of the contacts, so that it doesn't interfere with their ability to keep moving and being as effective as they think they can, which obviously can be extremely dangerous, not only from a perspective of substance misuse and opioid use disorder, but also pain. We've evolved to experience pain for a reason, as a warning system for us. And then last here is access. And I think this is one of the things that really changed our minds a lot. I remember when I was being taught this in the beginning of my training, I was really surprised by this, because I had an experience more like this, that athletes actually were in a different kind of social circle in all the institutions that I attended. And it used to be thought that, how could an athlete who has practice and it has to go to school and has to do their homework and has to get up early and is tired from training, how could anyone use substances and still do all that? And what we know is that's not accurate for a lot of people. And so the access of being an athlete is, one, if you're in a high contact sport, for example, you're more likely to get injured, you're more likely to get prescribed a medication to help with that. So there's access from the medical system. There's also access to being in the elevated social status of being an athlete. You're more likely to get invited to a party, for example, and you're more likely to have someone share something with you. You're more likely to be in those sort of situations. And then there's also some literature looking at what they're describing as like a maladaptive subculture, which is, these are, folks who are using anabolic steroids, binge drinking, misusing opioids for recreational purposes, and et cetera. This is obviously a big problem, and so the NCAA has actually put out an athletics toolkit to help guide everyone involved in athletics and how we can be more effective in this space and protect and help our athletes. And I'm not going to go through this obviously with you, but I just highlight these important areas. I think it's really important to understand that when injuries occur, that those decisions should be determined by medical professionals. Shared the same thing with the athletes. I remember when I was competing in college and had a really big game against a really big competitor, got injured the night before in practice, was pushing the trainer, the doc, everyone to let me play. And they did, but they probably shouldn't have, because that injury still is not healed. And so, just the NCAA now is recommending that we should, these decisions should only be made by medical professionals. And also considering that when folks get injured, that it's not just the physical injury that's occurring. And I know you guys know this, and I'm sure you're all doing a great job with this, but the injury can really impact a lot of elements of their life, their social status. Say they were a star athlete, and now they can never play the sport again. Not only could that really change their social status and the way they feel about their life and their kind of their mood and everything like that, but also the lack of support and structure of having to go to practice, having to be accountable to their team and everyone else. And also some folks can even feel loss of identity. I'm I wasn't a swimmer, but I'm always a swimmer. I've swam ever since I was 5, and now I have these overhead use injuries in my shoulders, and I'm being told that I probably shouldn't do this anymore. And it was my dream, and I wanted to compete in Division I athletics, and et cetera, et cetera. And now that dream has changed, and so that can be really hard. So I'll pause there. I'll leave this up here as I'm chatting, so you guys can write this down. If you have any questions that you either don't feel comfortable asking during the Zoom session, or you think of later, or you just want to connect with me at any time, feel free to email me. At this point, if there's any questions that came up in the chat, I'm happy to answer them.
Yeah, Mitch, we have a few questions here. One of the questions is, if as a coach, I have an athlete on my team that gets injured, what are some signs of concern that we should look for?
Yeah, great question. Great question. So signs of concern in regards to substance use, a lot of things we're looking at in this age group is if you're seeing like a change in how they're interacting, their mood is changing. There's someone who, for example, was always on time for practice and starts becoming tardy, starts getting more confrontational with people, a little more angry outbursts. Their friend groups start changing. They start changing the way that they're dressing. Those sorts of things, like really dramatic changes in their behavior and their personality. That can be a big cue. A lot of the outbursts, like if they were a really calm person and then now, someone, just try to think of something in a sport, someone slide tackles them in soccer and they get up and they try to start a fight because they felt like it was inappropriate, versus before they would have just said like, hey man, come on, what are you doing? That kind of thing. And then, so those are sort of the personality behavior changes. Another thing, they're the physical signs. So if you start seeing people who with opioids maybe appear a little bit sedated, maybe a little bit out of it, you're in a team huddle and they're kind of nodding a little bit, you see their head bouncing, they're having difficulty keeping their eyes open. If you can look at their eyes and you're looking at the pupils, so the black part in the middle, most opioids when you're using them are going to have that part get smaller, and it's usually pretty easy to tell. So those would be some of the physical signs, if they're like falling asleep on the bench and that kind of stuff too.
Okay, we have another one here. What are some tips for starting a conversation with an athlete that you might have concern that there is some substance abuse going on?
Yeah, another great question. It's really hard. It's really hard to talk with anyone about this, but I think, I remember being 16 years old, knowing everything about the world. And so I know it's tough to approach teenagers about these sorts of things. I always counsel people that it's not going to be as effective if you come in with a confrontational approach. So if you come in and you're like, I think you're using drugs, I want to talk to you about it right now, kind of thing. That's not going to go as well as if you come in with like a caring, kind of non-judgmental, empathetic approach. And instead of jumping to a conclusion about what might be happening, you start off with some open-ended questions. Doing so also not in front of other people. And if you can get away with not singling them out in front of other people, so examples, if you can just kind of pull them aside where no one else can see you doing it and say, hey, can I talk to you at the end of practice, versus at the end of a team huddle at practice saying in front of everyone else, and John Doe, I want to see you after for 5 minutes, because that can be uncomfortable for folks. And then they have to go to their friends and say, what did coach want to talk to you about? And it's probably less effective. So some examples of some of the dialogue that you might use with them. One of the things I always encourage people to say is just, I've been noticing some changes in you and I'm concerned. Is everything okay? So it's less about being confrontational and less about, I think that you're doing bad things, and more about I'm genuinely concerned about you and this is what I'm seeing. And so sometimes you can be more effective with those sorts of approaches. And sometimes folks are going to just react really negatively and strongly to that. And they're going to say, no, I'm fine. Get out of my life. You're my coach, not my therapist or whatever. And, that maybe that's the reaction, but sometimes, folks are going to say to you, yeah, thanks for asking. No one's asked me this, no one else has even noticed this, and I'm really struggling. And, that opens the door. Of course, if you think that there's a lot of risky behavior going on, or you have a really strong concern and you approach the athlete and they have a strong negative reaction and tell you to get out of their life or whatever, you can always go to the athletic director, talk to their parents, because, at the end of the day, these are folks that we got to look out for. So thanks. These are really good questions.
And then kind of going off of that, what resources do you have or suggest that we could give to a player that we see would be struggling?
Yeah, good question as well. I think, you can always find this NCAA toolkit. If you have any questions about that, I know these are folks who are not necessarily at college level yet, but I think there's a lot of stuff that just pertains to athletics. As far as, things you would give to the student athlete themselves, I would offer to connect them with treatment, or a therapist, or anything that you think would be helpful for what they share with you. And I'm sorry to be a little bit vague about that, but you never really know what's going on, especially with child and adolescents, because a lot of the common pathways just come to look this way, where there's a lot of just emotional disruption and outburst and behavior changes and personality changes. And you might see something that you think might be substance related, and you might find out that they're being abused at home, or that their parents are separating and it's really hard on them. And so I think once you figure out, if they share with you what the issue is, then you'll know a better way to direct them. But I think in any direction, connecting them with a behavioral health resource can be really effective. And, of course, we're WellSpan Health, so I'm gonna plug us. Connecting with Phil Haven, which is our behavioral health service line. There's a 24/7 call center there. You can connect on our website, but depending where you're at geographically and where your connections are, I know LGH has a behavioral health service line. I imagine UPMC does. I know Penn State does. So there's a lot of resources in our region.
Great, thank you. I don't see any more questions. So thank you, Mitch, for your time and dedication and expertise that you shared with us today. I think a lot of that information was very helpful for us as coaches. Thank you to all the coaches for taking the time out of your day to join us. We hope that this information is helpful and you can implement at least one of these concepts into what you do as a coach for our athletes. Our future schedule for the rest of the week is we are back to an athlete workout for total body tomorrow. And then Friday, we have a cardio focused workout with myself. And then next week's coach's topic is sleep. And we will be joined by Brandy Gertis from our sleep lab. Again, we thank you for attending our coaches clinic tonight with Mitch Crawford. We look forward to continuing this virtual series with all of you.